As you can see from this first slide, in the endocrine PowerPoints, we're going to cover many different endocrine disorders such as hypo and hyperthyroidism, Cushing's syndrome and disease, Addison's disease, disorders of the anterior pituitary, as well as some scenarios on diabetes mellitus. So when we look at the first type of endocrine disorder we're going to discuss, we're going to look at the client who has hypothyroidism. Remember that there is that feedback loop, you can remember from your pathophysiology readings, where the hypothalamus actually produces TRH, thyroid releasing hormone, which acts on the anterior pituitary to produce TSH, which is thyroid stimulating hormone, which actually then will impact the thyroid gland to go ahead and produce the thyroid hormones, which are T3 and T4. It's a feedback mechanism because if there's enough T3 and T4 on board, then it shuts down the amounts of TRH and TSH that are developed, so that it helps to regulate those hormone values within the body. The pathophysiology of the thyroid gland, there are two different types of cells within the thyroid gland itself. The thyroid has follicular cells which actually produce the thyroid hormones, the T4 and T3 hormones. Remember, T3 is the more active form of the hormone. The T4 types of hormones are actually about 80% bound with proteins, so they're not quite as active as T3 is. The other types of cells found within the thyroid gland are the parafollicular cells, which actually produce calcitonin, which regulates calcium levels. Calcitonin actually decreases calcium levels within the body. Embedded within the thyroid are also the parathyroid glands, and these glands produce a hormone called parathormone, which is a hormone that actually increases calcium levels. So this would work the opposite of calcitonin. Iodine is essential to the thyroid gland for the synthesis of thyroid hormone production, and primarily iodine is found in seafood, bread, water, iodized salt, things like that. We've talked a little bit earlier on the hypothalamus pituitary thyroid feedback mechanism and what are produced by each of those areas that help to keep the T3 and the T4 levels at a good level within the body system. When there starts to develop problems within the thyroid, low thyroid hormone levels are related to hypothyroidism, and there are many different causes of hypothyroidism. One would be primary, and an example of that is where there's a defect in the gland itself where it can't produce or secrete thyroid hormones. And probably one of the most common causes of that is Hashimoto's thyroiditis. There's a very nice workup in your book, so you can read a little bit more about that in your textbook. A secondary form of hypothyroidism would be if there's a defect within the pituitary gland itself, and the pituitary cannot secrete enough thyroid stimulating hormone. This could be due to a pituitary adenoma or something like that. And a third cause is if there's a defect in the hypothalamus where it is unable to secrete enough thyroid releasing hormone. And that could be another cause that could impact that whole feedback mechanism. Another problem could be if the patient had a insufficient ingestion of iodine and those types of things, or had an excessive intake of foods that contain thyroid inhibiting properties. So some of those foods could be like cabbage, turnips, soybeans, peanuts, peaches, strawberries, things like that. Remember, your thyroid gland does a lot of metabolic functions for your body, so if there's not enough thyroid hormone on board, typically these are some of the signs and symptoms that will be seen. Patients will have low heart rates, be very sensitive to the cold, have low body temperatures, have trouble with wound healing, they will bruise very easily, they will have a poor appetite with weight gain, constipation due to decreased GI motility. Patients will have problems with anemia. The skin will be very coarse, dry, inelastic. Patients that are of reproductive age will have very heavy menses. Nails will be brittle. They'll have hair loss, weight gain, numbness and tingling of the hands or feet, and they can start to have neuro problems such as thick slurred speech, and aching stiff muscles and joints and slow muscular movements. Men might notice decreased libido and impotence with hypothyroid types of issues. The nursing situation that we're going to use for this endocrine lecture is going to be a 38-year-old woman who's attending graduate school. Chief complaint is overwhelming fatigue not relieved by rest. And upon assessment in the endocrine lab, it's found that the patient complains of being cold all the time, has no energy, bruises very easily, feels achy, and as you can see, has a low temp and heart rate upon a physical assessment. If we look at her particular vital signs, this is a common finding with the patient with hypothyroidism. Decreased cardiac output, blood volume, decreased respiratory rate, and anemia are very common findings, along with the bradycardia and the hypothermia. So, and that's due to the functions that aren't available if the thyroid hormones are too low of a level in the body. So some questions that we would want to ask this particular client would be to describe her fatigue, when it started, what makes it worse or better. In other words, what are the aggravating or alleviating factors? If she's had recent changes in the appetite and in her weight, temperatures, if she is bothered by cold temperatures, if she's had problems with constipation at all, and if she's had any chest pain, swelling in the extremities, or anything like that. Other things that we would want to make sure are included in her general assessment are any changes she's had in her menses, any family history of different kinds of diseases, including hypothyroidism, and if she's had a lot of stress or any things like that. Hypothyroid is about 5 times more common in women than it is after men, and it's also more commonly found in middle age. She would have some lab workups done to look and see what the values are, and this is a typical finding of a patient that does have hypothyroidism, especially if it's primary. That patient would have decreased T3 and T4 thyroid levels, but would have an increased TSH because of that feedback mechanism. So the TSH, remember, with these particular patients, the TSH elevates because it realizes there's not enough T3 and T4 on board in the body, but because the thyroid gland is not able to produce T3 and T4 adequately, the TSH just keeps climbing higher and higher, trying to activate the thyroid, which is not able to do its job anymore. The other things that patient will probably have ordered would be like an anti-thyroid antibody titer, a radioactive iodine uptake scan, a thyroid scan, a free T4 to find out how much T4 is actually on board and unbound to protein. And you can read a little bit more on some of those lab tests in your textbook. Typically, these patients are going to be put on Synthroid as the typical main medication that these patients would have. So with Synthroid, some things that we'd want to teach the patient is to take it before breakfast on an empty stomach. It does interfere with certain medications, so the patient needs to make sure that they're being careful with that. The patient never wants to stop or substitute this med. And some side effects would that the patient, if the Synthroid levels are too high for that patient, the patient may feel that they have a bounding pulse, so they need to be checking what their pulse values are and things like that. As part of education, we'd want to teach that patient that it is a synthetic T4. Typically, Synthroid started at a very low dose and then titrated higher to get effective results for that particular patient, and it's based upon their lab tests. And typically, we need to watch for hypertension, heart failure, MI, chest pain, or dyspnea for those patients that get too high of levels of Synthroid. Teaching points for these patients also would include to have a well-balanced diet, exercise and rest, good skin care. For the hypothermia, they have good clothing because of GI, poor motility, treat constipation issues, monitor the pulse. And remember, Synthroid can have a negative effect on certain meds. It can increase glucose levels. So if the patient's also a diabetic, there needs to be care there in watching what the blood sugar levels are. It also can have some effects on digoxin. It can actually increase the effects. So the patient may need dig doses adjusted. Same as it can also increase the value or effects of anticoagulants and some anti-inflammatory medications given for rheumatoid arthritis. So these patients may need adjusted dosages on those meds. Typically, patients with hypothyroidism are also very sensitive to hypnotics and sedatives and may need less and a much lower dose than a typical patient because they're very sensitive to this. The patient is at risk of developing mixed edema coma. So this is a rare but very serious type of a side effect from patients that have hypothyroidism. And client education would include to be aware of things that can precipitate a mixed edema coma. And those include illness, stress, infection, trauma, surgery, exposure to cold temperatures, or if that patient would rapidly stop their thyroid medication. So the unfortunate thing is it can lead to cardiac and respiratory failure and shock, and even death. So patients need to wear medical alert bracelets so in case the patient would ever develop this type of a problem. Some signs and symptoms that patient would have if they developed a mixed edema coma are listed here for you. So typically those patients get very hypotensive, low heart rate, they get very low temperatures, blood sugars drop, sodium levels drop, and respiratory depression and coma can result. So these patients many times are in an ICU setting with perhaps respiratory support from a ventilator. Nursing care for these patients that have this type of a coma would be in an ICU setting. Typically they're given glucose and sodium since their levels are typically low during this particular scenario. Patients are watched for arrhythmias on the EKG. They're given steroids, IV, and that's also to help with the adrenal cortical insufficiency that's going on with it. The underlying cause that triggered the mixed edema coma is treated. The patients are kept warm with blankets. Sometimes warming blankets are not used with these patients because the lights and functions of the warming blankets can cause so much peripheral dilation, which may worsen the signs and symptoms of the hypotension and shocky symptoms that these patients have. So they're monitored very closely, and obviously due to their response to sedation is avoided on these patients. So an NCLEX question is, a client admitted to the ER where a diagnosis of mixed edema coma is made. Which of the following nursing actions does the nurse prepare to carry out initially? And the correct answer would be 3. Remember, we always want to do our ABCs before we do anything else. Once you have your airway, breathing, and circulation stabilized, then you can go ahead and move on to those other interventions that are listed. The second NCLEX question looks at, before administering Synthroid to a client, what should the nurse always do first? And the correct answer is you always want to check patient's pulse, because remember, Synthroid can increase metabolism, which can increase that client's pulse rate. The second part of this initial endocrine lecture looks at the counterpart of hypothyroidism, which is hyperthyroidism. And please refer to your textbook for additional information on this subject. This is sometimes referred to as thyrotoxicosis, where you see elevated thyroid hormone levels. And when we think about what that does to the body, that will then increase cardiac rate, which will lead to increased cardiac output, peripheral blood flow, and also increase in carbohydrate, protein, and lipid metabolism. So probably one of the most common causes is Graves' disease, which is an autoimmune disease that is probably about 60% of all cases of hyperthyroidism. Could also be because of an excessive secretion of thyroid stimulating hormone or thyroid releasing hormone. So that could be perhaps due to a pituitary adenoma or neoplasms, those types of things. or it could be due to an excessive ingestion of thyroid medication, that patient that had been on too high of levels of Synthroid or other types of medications. Severe emotional or physical stress many times precipitates the onset of symptoms with hyperthyroidism. This slide lists some other signs and symptoms seen with hyperthyroidism. So those patients typically will be having weight loss without any change in appetite. They may also have diarrhea, elevated body temps, heat intolerance, insomnia, palpitations, sweating, and they may have fine hair or hair loss on the scalp, eyebrows, and other areas. And the patient may also exhibit symptoms of a goiter, which is that swelling around the thyroid area. And we'll look at a picture of that in a few slides. This just shows President and Mrs. Bush. Actually, they both developed hyperthyroid after the Gulf War crisis. So Mrs. Bush developed it after re-election. So it does show how stress and the effects of that on the body can cause these problems. The nursing situation we're going to have with hyperthyroidism is an 80-year-old woman who comes into the outpatient endocrine clinic admitted to the hospital for flu-like symptoms for the past 5 days. She also complains of dyspnea on exertion, palpitations, chest pain, insomnia, and fatigue. And this particular patient was diagnosed with Graves' disease about 6 months ago. Other findings that may be noted that indicate hypermetabolism include anxiety, restlessness, insomnia, increased systolic blood pressure. The patient may have palpitations, arrhythmias, and tachycardia, may have dyspnea, elevated temp, and low weight for height when looked on graph charts and those kinds of things. Please refer to your textbook for a great nursing care plan that looks at a client with Graves' disease. This slide depicts some of the problems that we've talked about earlier. This slide to the left is a patient with an extreme form of a goiter. And one common finding that's seen in patients with hyperthyroidism is visual disturbances such as exophthalmos. It's also called sometimes Graves' ophthalmopathy. And with this particular disorder, there is an accumulation of fluid in the fat pads behind the eyeballs, and so you get an inflammatory edema in the extraocular muscles, and this causes the eyeballs to protrude, as noted in this picture there. Probably about 50% of all people that have Graves' disease will actually develop this visual disturbance and the exophthalmos that's noted there. These would list several good calls for nursing for patients that have this particular disorder. So decreased cardiac output, activity intolerance, ineffective coping, nutrition issues along with sleep pattern problems, sensory perception problems due to visual changes, and knowledge deficit. And refer once again to your textbook, the care plan that's listed for Graves' disease. Nursing interventions include to monitor for those signs and symptoms that we may see with the patient, such as tachycardia, palpitations, elevated blood pressure, arrhythmias such as atrial fib. The patient may also have angina, dyspnea, and possible symptoms of congestive heart failure due to the increased myocardial oxygen consumption and increased cardiac output and the changes within the body due to the excess of thyroid hormones on board. For activity issues, trying to keep that patient cool, keeping them quiet, encourage them to rest will help a little bit with those issues. And also with patients with nutritional issues, trying to avoid coffee, teas, colas, and spicy high fiber foods that might aggravate the GI system. Having that patient eat 6 frequent meals per day that are high protein, high calorie, taking supplemental vitamins, doing a good GI assessment on these patients and monitor their weight loss and diarrhea issues and things like that. Education for these clients will include to report to their primary care provider any symptoms of palpitations, dyspnea, vertigo, chest pain, all those types of things. Treatment of hyperthyroidism can actually include many different modes depending on the patient's particular problem and the patient's past medical history. The patient may be treated with medication alone, or they may be treated also with radioactive iodine therapy. If either of those methods are not effective for the patient may require surgery for their hyperthyroid state. Some medications typically used for patients that have hyperthyroid would include PTU, which is propylthiouracil. This actually blocks the synthesis of thyroid hormones within the thyroid gland. The patient will take it until they're euthyroid, which means their thyroid levels are back to a normal range. And the patients will need to have periodic WBC counts done because these drugs can cause agranulocytosis, which is a decreased WBC count, and so they have a decreased ability to fight off infections. These patients should report anytime they have sore throat, fever, sepsis, jaundice, anything like that, due to the changes with the PTU. Another medication is called SSKI or Lugol solution. This actually decreases the vascularity and size of the enlarged thyroid gland, and it can be used in conjunction with other anti-thyroid medications to try and decrease the amount of circulating thyroid hormone levels that are within the body. The last one is more of a symptomatic measure. The patient may be put on beta blockers to just decrease those palpitations and cardiovascular symptoms that they may have due to the effects of the excessive hormones on board. Radioactive iodine is one of the treatment options we touched on as a treatment for hyperthyroidism, and radioactive thyroid is typically given in a dose just orally. We're going to talk a little bit on the next slide with it. The picture to the right shows that sometimes patients, if radioactive iodine or medications are not effective, they may need surgery, especially if those patients have thyroid glands to the point that they're so enlarged they're putting pressure now on the esophagus or trachea, or that patients now having swallowing or breathing problems, then surgery may be required for those patients. Radioactive iodine therapy is also known as I-131, and this is actually a medication that the patient would be brought into a hospital setting to take because obviously it's radioactive. They're brought down into the X-ray department of the hospital, and the patient is put in a special room. The person who administers it actually has radioactive precautions in place as they administer this medication to the client. Typically it can be taken as a pill, or it can be taken as an oral solution, and most often one dose is going to be sufficient for treatment for these patients. About 85% of all patients will be cured with just one dose of this. Once in a great while, a second or perhaps a third dose may be needed. It depends on the amount of thyroid gland that gets destroyed by the first dose of the I-131. What happens with this is it is given and it actually destroys the thyroid cells by local radiation. And it usually takes about a 6 to 8 week period or so for this to actually happen. After 1 year the patient has been on this medication, typically the patients then sometimes will become hypothyroid because so much of the gland will be destroyed by the radioactive thyroid that they've taken. So just to show some stats, 10% of patients will be hypothyroid after 5 years following I-131 therapy. 30% will be hypothyroid after 10 years, and 90% of patients will be after 10 years. I'm sorry. 1 year after therapy, let me restate that one more time. 1 year after therapy, 10% of patients are hypothyroid. 5 years after therapy, 30% are, and then 10 years after therapy, 90% are. So in other words, some of these patients will end up in the long road actually needing Synthroid because they get to be where the function of the thyroid is completely destroyed, and then they have no hormone levels on board whatsoever. Some precautions that the patient needs to know about with this particular therapy is because it is radioactive, those precautions are needed. It's excreted in the urine, saliva, sweat, and feces for about 24 to 48 hours after the patient has taken it. So they need to avoid close contact with children for a couple of days, flush the toilet 2 to 3 times after use, avoid kissing for several days, and women should not become pregnant or breastfeed for approximately 6 months if they have been treated with I-131 therapy. Surgical management for these patients would be reserved for those patients that had perhaps already tried anti-thyroid medication or I-131 and it had not been effective, or if that patient has a goiter that is so large it's compressing, as we talked about earlier, on the trachea or esophagus. Typically, the patients will have a subtotal thyroidectomy. Usually about 80% of the gland is removed. They don't typically take all 100% of the gland. The patient may require an entire thyroid gland removed if the patient had cancer of the thyroid or something like that. So with these particular patients, after they had had this particular surgery done, some post-op measures would be to make sure the head is kept in good alignment. The head of the bed is elevated in a semi-Fowler's position. The nurse needs to assess for drainage, and remember to look behind the neck. There's surgical incision will be anterior to the neck, but there can be pooling of blood posterior and under the neck, so that's an important thing. If you ever have a patient that has a neck wound that's in the front of the neck, always check to make sure that there hasn't been pooling of blood that's run down the sides of the neck and has pooled behind the neck on the pillow for the patient. Also look for hoarseness and trouble talking with these patients. They may have edema, laryngeal edema post-op. Look for airway patency and have suctioning, oxygen, tracheostomy equipment at the bedside in case that patient would get into respiratory distress. Because these patients are at risk that the parathyroid glands could also be removed or have been damaged during the surgery, the patient's at risk for developing low calcium levels, so make sure that the patient has calcium gluconate readily available in an IV form in case the patient would need it. There are a couple of signs to look for to see if that patient would have low calcium levels. These are a couple quick assessments that you can actually do at the patient's bedside. The first one is Schwaddick sign, and that patient would be positive if when tapped on the face slightly over the facial nerve just below the temple, if the nurse tapped on this area and the patient had facial muscle twitching over that area, that can be indicative of low calcium levels. Another quick assessment tool to use is called Trousseau's sign. And with this sign, the patient actually has a blood pressure cuff that's put on their upper arm and left inflated for about 2 minutes, and the patient will start to have palmar flexion and carpal spasm, which can indicate low calcium levels. So this particular scenario says what happens with that patient scenario where the patient seems to get worse. Patient perhaps come into ER and has symptoms of hyperthyroidism and then starts to develop a temperature of 103, elevated blood pressure, elevated pulse, irregular rhythm. Patient may be noted to be in atrial fib, elevated respirations, and are labored. So in this instance, what's happening with this patient is they're actually going into what we call thyroid storm. And with thyroid storm, this is a rare, life-threatening medical emergency. The patient will have extreme symptoms of hyperthyroidism, and some of the common triggers that can cause thyroid storm would be stress, infection, trauma, untreated diabetic ketoacidosis, manipulation of the thyroid gland during surgery, or if that patient would abruptly stop taking thyroid meds. Typically, patients that are going to have surgery done on the thyroid gland are given medications before the actual surgery to try and bring those thyroid levels down as much as possible before the patient would actually have the gland removed, so that there's not a large outpouring of the thyroid hormone when the gland is actually cut into or removed during surgery. Signs and symptoms of thyroid storm: the patient may have a body temp as high as 102 to 106. Patient will be tachycardic, may have systolic hypertension, abdominal pain, vomiting, and diarrhea. Patient may also be extremely restless, agitated, have tremors, and it may result in the patient actually looking as if they've developed some sort of a psychosis, delirium, that type of a thing. So these patients need to be monitored very closely because it can lead to vascular collapse, coma, and thyroid storm can even lead to death. So important interventions for these patients. They would also be monitored in an ICU setting on a cardiac monitor because they're at risk for arrhythmias that we've talked about earlier. The patients would need IV fluids. Typically they would be at risk for dehydration, so we need to watch for fluid volume deficit or overload issues. Watch the ABCs, keep the patient on O2. The patient can be put on a cooling blanket to help bring that temperature down and try to promote to regulate that hypermetabolic state they have. Typically we'll give them anti-thyroid meds, iodine, large doses of iodine to help decrease the levels, steroids, beta blockers, typically to also help bring down the temp. The patient may be on Tylenol. Aspirin is not given because it can actually increase thyroid hormone levels. So instead they're put on acetaminophen or Tylenol.